Good afternoon and welcome to this Molecular Tumor Board session. My name is Phillipe Afthimos. I'm a medical oncologist at Insitut Jules Bordet in Brussels, and I'll be moderating this session with esteemed panelists. We are going to present a few cases. We have prepared many, and then the number will depend on the time and the discussions we're going to have. So the format's going to be introductions first, and then like 5 minutes to present molecular tumor boards in general, and then we'll start with our cases. We are going to leave the chance to have a couple of questions after every case. These are my disclosure information. One is relevant to this session, as I received funding to my institution within an academic program to set up a national molecular tumor board in Belgium. So these are your panelists today, so we can start with the introductions. So Dara.
My name is Dara Aisner. I'm an anatomic and molecular pathologist at the University of Colorado, where we do a lot of personalized medicine, precision genomics testing, and we do that across all tumor types. And I'm also personally a breast cancer survivor, so I have a vested interest in all of these things.
Jorge?
I'm Jorge Reis-Filho. I'm the Vice President for Cancer Biomarker Development at AstraZeneca. I'm a card-carrying pathologist, but then out of necessity rather than by design, I had to retrain as a computational biologist, struck bioinformatician, now morphed into an AI person. Prior to joining AstraZeneca, I was the Chief of Experimental Pathology at Memorial Sloan Kettering. Such a pleasure to be here with you today.
Phil?
Hi, Phil Bedard. I'm a medical oncologist at the Princess Margaret Cancer Center in Toronto, and I direct our cancer genomics program.
Jenna?
Hi, I'm Jenna Canzoniero. I'm a breast medical oncologist at Johns Hopkins, and there I have a translational lab looking at using circulating tumor DNA to guide therapy for patients with breast cancer. And I also help direct the Precision Medicine Initiative for our group and also help to lead the molecular tumor board at Hopkins.
Good. And I'm Bob Riter, a patient advocate from Ithaca, New York. I was diagnosed with breast cancer 28 years ago, prostate cancer about 5 years ago, and I have a CHEK2 mutation.
Thank you. So why tumor boards? Molecular tumor boards are a setting where we discuss treatments and molecular results, but they're also an educational opportunity. And you can see in this slide from a paper published a few years ago that when they did a survey about the confidence in using genomic tests in practice, confidence was quite high when you use single gene tests. But this is something we rarely use now in our clinics, and we move to next generation sequencing. And using commercially available multi-marker somatic panels, you see confidence decreases. And then if in the future we get to whole genome or exome sequencing in our clinics, the confidence is going to be very low for practicing oncologists, thus the importance of molecular tumor boards. Now, what do we discuss at a molecular tumor board? So these are the elements of genomic testing. First of all, we need to know the test characteristics. Is it a single gene or multi-gene test? Do we look at hotspots? There are some QC metrics that show robustness and validity, such as cellularity and other aspects. The sample type, is this a tissue biopsy? Is this a plasma sample or liquid biopsy? And then when we get the mutations, their significance, are they somatic or germline, meaning hereditary? And then you have different types of genomic alterations, the single nucleotide variants, the copy number variants, and the fusions, and we'll have the chance to discuss them today. Now, how does a molecular tumor board work? So the aim is to identify and discuss potential therapeutic strategies based on genomic and genetic analysis. And this is a multidisciplinary discussion. We don't only look at the molecular characteristics, but also at the patient characteristics, including performance status, comorbidities, but also drug-drug interactions. And then we issue a molecular tumor board report that should have the patient identification, the molecular test characteristics, the sample info, all classes of identified molecular alterations, and then an interpretation. Now, who should sit on a molecular tumor board? And I think there are differences between institutions and between countries, but this is not an extensive list. So a medical oncologist, we know that now we are subspecialized, so subspecialties whenever relevant. Pathologist, geneticist, bioinformatician when needed, molecular biologist, pharmacist, ethicist, scientists and physicians with molecular expertise, study coordinators, because this is an opportunity to enroll patients in genotype-driven clinical trials, students as an educational opportunity. And then, Bob, this is something I think you'd find interesting. So in Spain, they have a program called HOPE, where patients drive their molecular test. They make the request, and they have currently an amendment where the patient will also sit on the molecular tumor board when their case is discussed.
That's great.
Now, to do this interpretation, you have a lot of databases for looking at the pathogenicity of a variant, but also to try to link variants with drugs and clinical trials. And this could be a lot of work, but this is now being streamlined with the development of tools optimizing virtual molecular tumor boards. This can be a platform for presentation, but also some tools that incorporate all these databases. I don't know, George, if you want to comment on that.
Yes, thank you so much. It's such an interesting opportunity now, given the development of these large language models that allow for their agentification. You can integrate all of this information, these different databases, and even interact with the physicians as well. I think that the opportunities to democratize the access to molecular tumor boards in a really effective manner will be enhanced by the developments in the AI world. So watch this space. I think this is coming together in a really exciting manner.
Thank you, George. And then finally, we need to look at what data is out there, the levels of evidence. So there are multiple tools now to rank the genomic alterations that we find, because a genomic alteration is important, the context is also important, and the evidence that we have collected. And in this study in metastatic breast cancer called SAPPHIRO-2, the learning is when you target a molecular alteration with a high level of evidence, and in this study they used the ESMO scale that is called SCAT, so level 1 and level 2, these are the highest levels of evidence for molecular alteration. You see that the patient outcome is better. So you have a prolonged progression-free survival when you use targeted therapy versus standard of care. Whilst if you use genomic alterations that are with less levels of evidence, there was no difference in the study. So with that, we can maybe go to our cases. So the first case is a case of hormone receptor positive, HER2-negative metastatic breast cancer with multiple genomic alterations. So we are going to discuss the impact on first-line therapy. How do we prioritize target, but also the input of liquid biopsies. So the patient is a 60-year-old lady who was diagnosed in 2013 with invasive ductal carcinoma, PT2 and 0, grade 2, estrogen receptor positive, PR negative, HER2 negative. She had surgery, she had adjuvant chemotherapy, FEC followed by docetaxel, and was on an aromatase inhibitor letrozole as adjuvant therapy. And in 2016, she presented with metastatic relapse in the liver and the bones, and you can see here images from the CT scan, and you see the multiple liver mets. So I would like first to ask a question to George. So how important is a biopsy here?
From the perspective of understanding the evolution here, it can be incredibly informative, given that the heterogeneity in a tumor with this profile, starting from that baseline of it being ER positive but relatively high proliferation, we can expect that there will be some degree of genetic instability that can result in heterogeneity. So having a sampling of tumor DNA here would be important through a biopsy here, or in this case, through more comprehensive sequencing by plasma DNA as well.
Okay. So this patient had the liquid biopsy, and you see in this slide how we can use liquid biopsies based on circulating tumor DNA. We're not going to discuss today early cancer detection, but this is something to watch out for the future. It's in a very important space for screening for cancer. You can also use it as surveillance for micrometastatic disease after the end of adjuvant therapy. And what we're interested here is the treatment selection and response monitoring. And treatment selection meaning that we can identify these alterations in DNA from plasma. So maybe a question for you, Jenna. So can you base your treatment mainly on a liquid biopsy without performing a tissue biopsy? What's your take on that?
I think in general, yes, but it depends a little bit about specifically what alteration you're looking for. I think there are certain types of alterations that are easier to detect in liquid biopsy or in tissue sequencing compared to liquid biopsy. So specifically thinking about PTEN loss is very difficult to detect in liquid biopsy. But in this case, with these two targetable alterations that were detected, I think that that's probably sufficient. I would say the other place where we sometimes run into problems is if there's low circulating tumor levels in the liquid biopsy. And so then if you're not detecting something, that doesn't necessarily mean that it's not there. And then I would maybe want to pursue tumor tissue sequencing at that time.
And I think this is such an important point, that a negative result, depending on the limit of detection of the assay being used, does not equate with the absence of that molecular alteration in cancer cells. And we have to separate those two concepts. A positive result has one level of significance in terms of treating the patient here. The absence, depending on the levels of ctDNA in the plasma, may not mean the absence of the alteration, maybe the absence of detectable ctDNA with that sampling, with that assay.
Right.
So we need to have this very clear in our minds.
And a question to Bob. So the advent of liquid biopsies, is this a game changer for patients? How do patients feel about that?
I think patients are excited about it, but we're also wary just in terms of not quite knowing when it's really ready for prime time. I think it has exciting information, but we're looking towards our oncologists to really guide us with how to use that information.
So a liquid biopsy was performed using next-generation sequencing panel, and two alterations were identified: a mutation in SR1, which is a gene coding the estrogen receptor, and a mutation in PIX3CA. Dara, can you guide us through the results? So what does the numbers mean after?
Sure. So I'll start by saying that what you're seeing here for ESR1P.D538G, that P dot refers to the protein coding sequence. So in the parlance of molecular diagnostics, a P dot is a protein change, and a C dot is a coding mRNA change. And so you might see those on all of the reports that come out. And it's important to understand that the C dot is there in large part for people like me to be able to read in my lab, to be able to look down to the level of the individual nucleic acid. So if I'm testing a comparator sample, it's possible to get a ESR1 mutation with the same P dot mutation, but different C dot mutation. So both of those pieces of information are important. These are both single nucleotide variations, and both of them are known to be activating. And the VAF that's listed here at 5.9 and 13.1 is the proportion of all of the reads in the assay that are showing the mutation. And I think it's really important to understand that VAF can be very useful to infer pieces of information, but it's also very easy to over-interpret VAF and draw more meaning out of it than might be there. So I think interpreting VAF is actually very nuanced and is something that oftentimes the data that comes out in the report doesn't give you enough information to fully interpret what a VAF might mean.
Thank you. So Phil, now we're going to, so this is a patient with a hormone receptor positive HER2-negative metastatic breast cancer that relapsed 3 years after starting adjuvant letrozole. Would these results impact your first-line therapy?
Yeah, so definitely. I mean, I think it's important to know this information. Perhaps it's not entirely surprising, particularly the ESR1 variant, given that this patient is relapsing on letrozole. I think there are a few important clinical considerations. First of all, you want to know how well the patient is clinically, what their liver function is, because the scan that you showed pretty extensive metastatic disease. The clinical course is important as well. This is a patient who had a relatively low-risk breast cancer. T2N0 was treated with an anthracycline taxane chemotherapy, then had adjuvant endocrine therapy, and is now relapsing about 3 years after diagnosis. So that tells you something about the biology, potential endocrine resistance. So in this case, with the ESR mutation, having relapsed on letrozole, you would avoid, if you were choosing endocrine therapy, another aromatase inhibitor, and would prefer a selective estrogen receptor degrader like fulvestrant. I think the standard of care would be to consider a CDK4/6 inhibitor as well. And now there's recently a drug approval, and this patient would have been eligible for the INAVO 120 trial to also consider inavolisib, which is a alpha-selective PI3 kinase inhibitor that also is a mutant degrader. So those, provided that the patient was well and had adequate liver function, those would be my thoughts in this situation.
Okay, thank you. Yeah, so those were the questions. So, well, based on the guidelines, the patients would have received endocrine therapy and a CDK4/6 inhibitor, as Phil said. So the INEVO data is not yet in the treatment guidelines, at least for ESMO. I think it was recently FDA approved. And upon progression, what would you do? No?
I would sequence again. I would get another liquid biopsy
Okay.
and see if there are any potentially new emerging mechanisms of resistance, and then think about enrollment on a clinical trial.
Okay. So just put a slide about some of the data we have on the mutations. So ESR1 mutations in the second-line setting can also make patients eligible for treatment with the novel oral SERDs. So elacestrant was approved by the FDA a few years ago, and yesterday we saw the data from EMBER-3. And then I also put the data coming from the SOLAR-1 study, which got alpelisib approved. And I chose this slide because this shows you that you can be confident in the result of a PIK3CA mutation coming from a liquid biopsy, and you get the same benefit. So when you have different alterations, how do you, and this is a question for Jenna and Phil, how do you prioritize which one to target first?
Well, I think you consider the patient context, and then you look at the concept of clinical actionability. So you want to know which mutations are really biologically important and which are associated with predictive benefit from a drug. So in this situation, you have two potential level 1 alterations that have been identified with the circulating tumor DNA test that can inform your decision-making.
As much as we can, I like to try to combine things, so that's why I like clinical trials where you're doing combinations.
Indeed, so I chose this slide from the EMBER-1 study. So this was a phase 1 study testing the novel SERD imlunestrant, where there was a combination of imlunestrant and alpelisib, which was quite active. So I don't know if there are any questions regarding this case from the audience. We have a couple of questions online. Okay, so I'll go to the online questions. So one question is, are we worried that this patient may have lost the RPR expression? So should we push for a biopsy? And I think you discussed that, George. So.
In the evolution, we do observe a small but significant proportion of patients that actually evolve to become not estrogen receptor positive anymore or dependent anymore. And I think it's very important, as it was mentioned before, that we understand what's the trajectory of the progression, because there are multiple ways that breast cancer and ER-positive breast cancer can become resistant after all these lines of treatment that we're opting to have here.
Okay. And the second question, so I would say this would be for Dara and George also. So when you see multiple clones on liquid biopsy, do you know which one is actually the driver mutation? Can we assume the one with the highest percentage as the driver?
The short and the long, just having the VAF there, no.
Yeah, I agree. I think it's very hard to extrapolate VAF into assumptions about clonality. You know, on first pass for the case we're talking about, you could say, oh, well, the PIK3CA is the driver and the ESR1 is subclonal. That's entirely possible, but there are alternate explanations for those VAF distributions that you really can't exclude. So I think it's important to understand that when you're thinking about a heterogeneous disease, that all of the ways that heterogeneity can contribute to variable numbers can be true at an individual site of disease and in the periphery.
And I think it's very important for us to acknowledge here that to understand the clonality, we need to derive local copy number information and ploidy. And based on a ctDNA assay, this is by no means a trivial task. Yeah? So I think extrapolating VAF in a context exactly like this case, to say this is clonal, this is subclonal, would be very, very challenging.
Thank you. And there are many questions, but I think I'm going to ask a last one. So can you use the variant allele frequency to monitor response?
Again, I really struggle to suggest that monitoring VAF in isolation can be the best approach. I think when you're putting it in the context of other pieces of information, it is another piece of data that you can use. But again, this concept of global heterogeneity, I think, can really contribute to VAF being a confounder as opposed to something that is very straightforward. You know, the example of needing local copy number plots, I think, is really important because, you know, using this PIK3CA example, if one site of disease has PIK3CA mutation and amplification, then you're completely shifting the VAF profile in a way that isn't really reflective of the global disease as much as it is that one site.
Or thinking the other way around, if on chromosome 6 there is a duplication of the wild type chromosome 6, you see the SR1 mutation, it looks lower VAF, but it does not mean that less cells. I think one interesting concept, however, that is becoming more and more adopted is the idea of molecular responses versus ctDNA fraction, when you can calculate that ctDNA fraction, which is still not a trivial task depending on the footprint of your ctDNA assay.
Thank you. So we're going to move to case number 2, which is a case of a patient with lobular metastatic breast cancer and a high tumor mutational burden. So this is a 50-year-old postmenopausal woman with no family history of breast or ovarian cancer that came in for a large left breast mass, more than 7 centimeters. The biopsy showed invasive lobular carcinoma, grade 1, hormone receptor positive, HER2 negative with a Ki67 less than 10%. Chest X-ray, liver ultrasound, and bone scan were negative for metastasis. So this patient was treated with neoadjuvant chemotherapy, anthracyclines and taxanes, and obviously there was no response to this neoadjuvant therapy. At mastectomy, there was a tumor that was still 7 centimeters and 1 positive lymph node. She then had radiotherapy, and then 10 years of tamoxifen and switched to an aromatase inhibitor was not tolerated. So I'd like to ask George a question about the lobular histology. So how interesting is that, and is it easy to diagnose lobular breast cancer?
Lobular carcinoma is the most frequent histological special type of breast cancer. It's characterized by that so characteristic discohesiveness of the cancer cells. There are many, the classical variant presents as infiltrating the breast stroma as single cell or single cell files, but there are variants of lobular carcinoma as well, going from the pleomorphic, the solid, the trabecular, the alveolar. It's an interesting tumor in terms of reproducibility of the diagnosis. There are several studies now showing that the pure cases of lobular can be diagnosed with, let's say, a good agreement across pathologists, but there is a number of cases where the agreement is far from ideal. And then the utilization of additional immunohistochemical assays like CDH1, icadiorin immunohistochemistry can help firm up the diagnosis as well, always in conjunction with the histology. There are also now approaches based on artificial intelligence to classify lobular carcinoma with a great deal of accuracy. There was a work by Freja Pareja from Memorial Sloan Kettering showing that you can attain very high levels of accuracy in the diagnosis of a lobular on the basis of computer vision.
So, Jenna, would you use MammaPrint or Oncotype in this case? So I'm just anticipating a question from online.
Lobular breast cancer tends to be less responsive to chemotherapy, as was seen in this case where this patient didn't have any response from neoadjuvant chemotherapy. I think it's still within the guidelines to use Oncotype for a patient along these lines, although if it was known to be T3N1, maybe not. But you know, I think the bang for your buck that you're going to get with chemotherapy is pretty low for lobular, definitely more endocrine therapy.
So the patient had a relapse 16 years after the primary tumor diagnosis, and I put a graph below just to show you that in hormone receptor positive HER2-negative disease, late relapses are not infrequent, and she had ovarian and bone metastasis, and she was treated with a combination of letrozole and the CDK4/6 inhibitor. And disease progression occurred after 20 months, so she got 20 months of her first-line therapy with the reactivation of bone lesions and the development of a liver metastasis. Now, just this slide to show you that lobular cancer can have different genomic alterations when compared to ductal. So I don't know if you want to comment that, George, also, regarding the differences in ductal and lobular and the number of mutations and the types of mutations you can get.
It's indeed interesting. The most striking difference, which is, let's say, an underpinning cause of the so characteristic dyscohesiveness of lobular carcinoma cells is the presence of CDH1 ecadherin mutations. And these are usually loss of function mutations and with loss of the wild type allele as well. We see additional alterations that are more frequent in lobular carcinoma, but thinking about the luminal genes, there's an enrichment for them. It's not exclusively in lobular here in this context. Different studies have highlighted different genes that have a slightly higher prevalence or significantly higher prevalence in lobular. In some of the target genes as well that we think like ERB2 mutations are reported to be more frequent in lobulars as well. An important observation, however, is that the repertoire of mutational signatures in lobular carcinomas appears to be different from the garden variety of, let's say, luminal tumors of other histologic types.
Thank you. So you mentioned the HER2 mutation. So this is a question for you, Phil. Do you treat in the metastatic setting differently lobular carcinoma versus ductal? Because in this slide, this was an interesting data coming from a study using fulvestrant and neratinib. All patients had ERBB2 activity mutations, ductal and lobular, but you would see that in lobular breast cancer, the response rate seemed a bit higher.
Yeah, I mean, I think definitely, as you alluded to, ERBB2 mutations occur at a higher frequency in lobular cancer. It's about 5% of patients. So these are different from HER2 or ERBB2 amplifications. So these are sort of hotspot mutations often that activate the tyrosine kinase domain of the HER2 receptor. So there is single-arm data to support that. I think it's also included in the NCCN guidelines. You know, the availability of that, I think, is a different question. That may differ of using, for instance, a HER2 TKI like neratinib in combination with fulvestrant plus or minus trastuzumab. So I think it certainly does speak to, as you highlighted, that there are opportunities for precision medicine in patients with lobular cancer, and I think it's important to know some information about whether or not there are any genomic targets that can guide therapy.
Mm-hmm.
So let's go to the genomic data. So this patient had a liver biopsy, and then those were the results. So she had the Foundation 1 assay. There was a P53 mutation in the helical domain, and then a tumor mutational burden of 33. So maybe Dara, can you comment the results?
Sure. So we see here a PIK3CA mutation, much like we saw in the last case. I do think it's important to note that there's also a KRAS mutation here, which when you think about targeted therapy opportunities, a built-in bypass mechanism that allows for sustained cellular signaling that would not be impacted by many inhibitors of the PI3 pathway is really, really important. The tumor mutational burden, I think, is also very interesting here. It's certainly uncommon for breast cancer to have this high of a tumor mutational burden. And tumor mutational burden as an assay itself also has some challenges, although what I will say is that at 33 mutations per megabase, I would expect that any lab that reports tumor mutation burden would call this a high tumor mutation burden.
My first question, looking at this high TMB, if the frequency of C2Ts and C2Gs in this case, and to think about APOBAC mutagenesis as the underlying cause rather than other causes of an increased tumor mutation burden.
Yeah, so So PIK3CA mutations are quite prevalent in hormone receptor positive HER2 negative disease. Jenna, would there be more frequent in lobular than in ductal, or would you believe that the prevalence is the same for PIK3CA mutations?
Again, here, it depends on the subtype of, let's say, the luminal subtype. As you can see here in this figure from the TCGA study, if you look at the frequency of PIK3CA mutation in luminal A and luminal B, it's different already. So given that this interrelationship between lobular and ductal and the molecular subtypes, you can see a higher frequency of PIK3CA mutation. And if you think about the apoBAC mutagenesis is associated with a higher frequency of some PIK3CA hotspot mutations. You expect a higher frequency in lobulars.
Thank you. So this patient got fulvestrant and alpelisib. Would that have been your first choice of therapy after CDK4/6? So she had 20 months on first-line endocrine therapy, and
Certainly at the time, it would have been my first choice. I would have definitely done a second-line endocrine-based therapy with something to target the PIK3CA. I think now we have other options other than alpelisib. We have capivasertib that was approved in the United States. So today, I may have a slightly different choice, but at the time, yes, I would have done alpelisib.
okay. And then Tom, I put the lollipop plot because this is something we discussed with Dara prior to the session. So you'd like to comment on the different variants?
Yeah, so on the right here, you see a plot of PIK3CA mutations, and the portions of it that are above the protein structure are the PIK3CA variants that are approved related to alpelisib. And I think what's important about this is that there's a number of known activating mutations that are on the bottom half of this chart, and those were not included in the approval. And so different drugs have different spectra of mutations that are considered cognate for different drugs. So alpelisib specifically, the trial that, the registrational trial included a smaller number of mutations, and for the newer drugs that are looking more at pathway alterations, the number of mutations has been more inclusive. So, you know, do I have biologic reason to think that one of these mutations on the bottom would be less responsive to alpelisib? No, I don't have biological reason to think that, but we don't have empiric proof from the level of the registrational studies.
Thanks. And Phil, would that impact your choice between capivasertib and alpelisib, the type of variant?
Yeah, I mean, I think as was alluded to by the other speakers, it's obviously important to look at what the variants are and whether or not they're included in the drug label. I think the other point that I would highlight, which is sort of the next generation of PI3 kinase targeted drugs that has entered the clinic and is in early phase clinical trials, is that these are now mutant selective inhibitors. So one of the challenge with PI3 kinase inhibitors has been the therapeutic index in terms of really sort of trying to drive inhibition of PI3 kinase and the effect on the wild type isoform, which can lead to hyperglycemia and other side effects. So these newer inhibitors may offer opportunities to hit the pathway sort of harder and present opportunities with different combinations with endocrine partners or others that may add to sort of different tools in our therapeutic armamentarium. But you know, time will tell with clinical trials that will be started whether or not these are any better than the sort of first and second generation of drugs that also inhibit the wild type isoform.
A question that I had here, Philippe, as I alluded to in the molecular report, there was that RAS mutation, G12, not the traditional hotspot mutation, but it's a hotspot codon. How do you interpret this collectively here as an oncologist?
So, as an oncologist, I would go back to the papers I've read mainly from the group at MSKCC that actually presented KRAS as a mechanism of endocrine resistance. So I would say this might have been the variant that was responsible for the relapse. But then so we did the fulvestrant and alpelisib. At the time, and maybe still now, I don't know how this impacts response. So obviously, the patient had 5 months of fulvestrant and alpelisib, bad tolerance, progression of disease, and so the question comes here. So we saw a tumor mutational burden of 33 mutations per megabase. So before I ask you your opinion, maybe by a show of hands to the audience, who would use an immune checkpoint inhibitor? would not? Okay. So maybe everyone from the panel, what's your take on that? I mean, high tumor mutational burden in a patient with a hormone receptor positive, HER2 negative lobular breast cancer. We see it, I guess, frequently in lobular.
Yeah, so my take, I mean, the median tumor mutation burden in hormone receptor positive metastatic breast cancer is 3. So this is, you know, 10-fold higher than that. So I think it does catch the attention, as George alluded to. Would I use, assuming I had access to it, because there isn't a drug approval in Canada that's tumor agnostic for TMB high, I probably wouldn't in this case because we have other established therapeutic options. And the studies that were done were single arm in patients who had, you know, chemo refractory disease. So I think in this case, there are other sort of more conventional therapeutic options that I would consider, like capecitabine or paclitaxel, or, you know, potentially also trastuzumab deruxtecan if the patient is HER2 low, before I would think about using an immune checkpoint inhibitor.
Okay.
I think in general, the benefit from immune checkpoint inhibitors in breast cancer has not been as wonderful and exciting as we've seen in things like melanoma or lung cancer. And I think, you know, what's approved now is just in the triple negative settings. So thinking about what the role for immune checkpoint inhibitors could be in the hormone receptor positive space, I think we really don't have very high levels of evidence or really much evidence at all about what that benefit is. And I think even though immune checkpoint inhibitors are well tolerated compared to chemotherapy, they do come with an entire whole host of their own special side effects, and that's very important when we think about what we're exposing our patients to. These are potentially lifelong toxicities that may not resolve after stopping the immunotherapy. And is that worth it? I want to see a stronger evidence of benefit before I'm necessarily willing to put that on, you know, outside of a clinical trial.
Okay. So why was immunotherapy discussed here? So TMBI is one of these tissue agnostic approvals, and I put a list here. So MSI high, high TMB, this is for immunotherapy, but that you have the BRAF inhibitors, the NTRK inhibitors, and the RET inhibitors. So, Bob, I seem to have forgotten you a bit. So,
It's okay.
the patient perspective on these approvals that are not linked to a disease, like these drugs that you can use in different disease types. So.
Well, I was just thinking, reflecting that I've been at this conference for about 25 years, and each year I know more and I know less. And even a very well-informed patient will be kind of lost. And you know, it sort of gets back to the issue of trust. We have to trust our oncologists to guide us through a very nuanced set of information now.
Okay. So I also asked you this question, and you speak about trust because, if I remember, I'm going to look at the next slides, but this patient didn't want chemotherapy, and ADCs were not available at the time. So we had a long discussion. There was a clinical trial with an immune checkpoint inhibitor. So this was a bit of a shared decision-making, and I think that's quite important. Unfortunately, she did not respond to, so the tumor did not respond to therapy. And this is also a discussion we've had this morning, Dara. So do you want to comment on TMB high in different disease types? So I had a few slides coming. So it has been shown to be more prevalent in lobular. There was this basket study that showed that patients' tumors could respond to immune checkpoint inhibitors, and when you see the color codes, you see that the responses were both in triple negative and hormone receptor positive. And then there was this paper that came out a few years ago in Annals of Oncology that showed you that actually it's not the same in different disease types. So can you comment on that, Dara?
Yeah, so I think the next slide shows a little bit about the different assays for tumor mutation burden.
Yeah.
And this is from a well-known study looking at multiple institutions and their tumor mutation burden readouts. And one of the things I think that's important to draw attention to here is that you're looking at a linearity across a very wide range. And if you actually zoom in on regions of these charts, what you find is that the agreement at the low end and at the very high end is actually quite high, and that this variability that we see in TMB assessments really tends to hover around the intermediate area, the gray zone of TMB high. And, I would argue that this is not an indicator that the testing is variable. I would suggest that this tells us that we don't understand the biology fully yet. And so the fact that there is this intermediate zone, this gray zone, that happens to be right around where the cut point is, that means that we're really not yet fully fleshed out in understanding what this measure means biologically. And in terms of using this as a therapeutic decision point, I think treating a TMB value in isolation of all of the other pieces of information has some risk associated with it. And like Jorge said, there are other reasons you can have a high tumor mutation burden. And if this is an APOBEC signature alteration, that might not, comport with the common neoantigen presentation hypothesis of why TMB is associated with response to immunotherapy. So I think TMB is a tool, but it's a fairly blunt tool for a very fine decision.
And I would agree with that 100%. And I think we always have to try and understand what is the meaning of a surrogate that we have, because the surrogate provided by tumor mutation burden can stem from many different biological causes. And when we think in terms of, well, let's say colorectal cancer, MSI high in endometrial, MSI high in poly mutations. But here in the context of breast, work from Sarat Chandalapati's team and Antonio Marra showed that the majority of lobulars, or luminal tumors, ER-positive tumors, lobulars, with a high or very high tumor mutation burden, the majority of these cases have as an underlying cause APOBEC mutagenesis. So then we are then trying to equate what we see in other tumor types as the cause of the increased new antigens or mutations in other tumor types, BMSI or POLE, with APOBEC mutagenesis. And it's challenging. I'm not saying that this should be discounted, but as discussed here, it needs to be taken into account with all of the other variables that we have for the tumor and the patient.
Thank you. Okay, so it's going to be our final case. So in the interest of time, we're going to discuss it and discuss the objectives of this case. So it's a patient with metastatic triple-negative breast cancer with a somatic BRCA1 mutation. So a young premenopausal woman, 35 years old, with a family history of breast cancer. After pregnancy, she had a triple-negative breast cancer that was early stage. She got a neoadjuvant chemotherapy, which was standard at the time of the case, EC dose dense followed by paclitaxel. She had residual disease, and she had metastatic relapse 18 months after the last chemotherapy cycle, which was 3 long nodules. The disease was, the biopsy was triple negative. PD-L1 at the time was not tested. And those are the treatments she had in the metastatic setting. She was in another institution where they performed surgery, and then she was enrolled in Keynote 355, the phase 3 study that got pembrolizumab approved. She got a partial response. She had a brain lesion that was treated with SRS. She had capecitabine, she had eribulin. And then she stayed in 10 months on a study with a combination of talazoparib and the bromodomain inhibitor. So talazoparib is a PARP inhibitor, and the study was recruiting patients without germline BRCA1, BRCA2 mutations. And you can see here the response she had before disease progression 10 months later. And actually the rationale for this combination was that the bromodomain inhibitor would downregulate BRCA1 and RAD51, rendering the patients the tumors sensitive to PARP inhibition. And actually there was nice response. I think the response rate in the study was 30%, but then with the advent of sacituzumab govitecan, the development of this combination stopped. Now, we analyzed a lung biopsy later after progression, and there we found what was described as a BRCA1 somatic mutation because the patient had germline testing, which was negative, and then we tested again for the same variant. So I don't know, Dara, if you want to comment germline, the somatic BRCA mutations. And yeah.
So one of the things I think to consider here is, given the strong family history and this VAF, the repeat testing I think is very reasonable to query again whether or not this might be a germline alteration. Another consideration, and I really think this is where you need to bring in genetic counselors, is whether this could be a germline mosaic condition. And, it gets really challenging because with a matrilineal history, it's a little harder to invoke a mosaic condition, but it's not unheard of. And so I think the question for somebody who is young with a strong family history in the setting of a negative routine germline assessment, I think querying somatic mosaicism or germline mosaicism is an important consideration.
Okay. So and I think another impact here is an ethical issue also. So when we, at least where I work, patients sign an informed consent form before doing genomic profiling, because we can have incidental findings that could be germline. So a question for you, Jenna. So does this mutation have any therapeutic implications? I mean, your group published a paper on a case that's quite similar. So what would you use as therapy for these patients? I mean, she had talazoparib, she responded. Did she respond because of this BRCA1 mutation or thanks to this BRCA1 mutation?
I would think so. So from TBCRC 048 was a study looking at the efficacy of PARP inhibitors in patients who had other HRD mutations other than germline BRCA1 and BRCA2. So that included somatic BRCA1 and BRCA2, and then also germline PALB2. And they did show, thank you. They showed very nice responses in those, particularly striking in the germline PALB2, but also seen in patients who had somatic BRCA1 and BRCA2 mutations. So based on that data, I would have used a PARP inhibitor for this patient, and I do think, and we never know 100% for sure what is the cause and effect of everything we see, but I do think that the benefit that she got out of talazoparib probably was related to the BRCA mutation.
And regarding mechanisms of resistance, so since this is going to be the last case, you can maybe discuss some of the mechanisms of resistance to PARP inhibitors now and these reversion mutations?
Yeah, so there's a number of different known mechanisms of resistance to PARP inhibitors. One of the ones that's seen more commonly is this idea of reversion mutations. So particularly for germline BRCA1, BRCA2, and PALB2 mutations, we've seen that the cancer will mutate in such a way that the original mutation, which most commonly causes premature stop codon, is sort of taken out and put back into frame. So then you have continuation. So that restores the protein and restores the efficacy of the homologous recombination repair and pathway. And so then patients become, or tumors rather, become resistant to PARP inhibitors. But there are several other mechanisms of resistance to PARP inhibitor as well. And so it's important when you have a patient like this who had done well on a PARP inhibitor, had a good response, and then develops resistance, that you're querying to try to figure out exactly what that mechanism is.
Thank you. So maybe we have just time for one final question before closing the session. Is there a question? So I'll take the final question from online. So, and this is maybe for anyone in the panel could answer. So how often would you repeat testing? Maybe Phil, you can start. How often would you repeat testing over the course of a disease?
Yeah, that's a great question. I think it depends on the clinical context. It also depends on the access to testing, the type of testing, and how that's going to inform clinical decision making. I mean, if in an ideal world, I think you would have frequent ability to reassess, because we're seeing how quickly at these conferences, the field is changing and there are new therapeutic opportunities, and in particular liquid biopsy testing and some of the advances around genomic characterization of those tests, I think can offer opportunities for non-invasive diagnosis, because in the clinical context, it's often challenging, notwithstanding the potential risk to the patient of getting a biopsy, but also organizing those types of tests, getting back a result. There is some advantage to having liquid biopsy testing where blood sampling can be done at a local clinic or closer to where patients live, and then you get a result back pretty quickly that you can use to inform your decision making. And sometimes some of these resistance alterations show up before patients have clinical progression as well.
Thank you, Phil. So with this comment, we're going to close the session. So thank you for your attendance, and the rest of the cases are available in the slide set that you can download. Thank you very much. And thank you for the panelists. So in breast cancer, the only indication where it's standard of care is first-line therapy for metastatic breast cancer. That's the only, because that's how you get access to immunotherapy in the first-line setting. In the early setting, you don't need PD-L1 to give immunotherapy. In other settings, immunotherapy is not approved. So that's the only